Hey, good afternoon. We are going to read the Kawasaki disease guidelines from the pediatric green book. Bismillah. Early treatment reduce mortality from coronary artery aneurysm. Okay, recognition and assessment, symptoms and signs. So all of us, we know the Kawasaki disease, characterized by a fever for 5 days or more, and 4 of the following. So this is the criteria how we diagnose the Kawasaki disease. So fever for 5 days or more, and 4 of the following. So fever plus 4. Okay. So which are those 4? It could be conjunctivitis. It should be bilateral, bulbar, non-exudative. Oral changes, red lips, pharynx, tongue, peripheral edema, erythema in the palms and soles, followed by desquamation, fingertips 10 to 15 days after onset of fever. So the desquamation of fingertips is not like an early sign we can see. It takes time to poop out. It takes 10 to 15 days for desquamation to happen after the onset of fever. Rash, polymorphous, no vesicle or crust, just polymorphous rash, no vesicle or crust. Lymph nodes, acutely enlarged cervical nodes, more than 1.5 centimeter in diameter. Evidence of an infectious trigger doesn't exclude Kawasaki disease. Presence of a coronary artery aneurysm with any one of the above features is diagnostic. So basically, this is the criteria that we are looking for in the to diagnose the Kawasaki. So fever 5 days or more plus 4, whether conjunctivitis, cervical lymph node, rashes, oral changes, and peripheral edema or desquamation. If you got a coronary aneurysm by doing echo with one which one of the above signs in the box, that's for sure is a diagnostic, and it's confirming. Other features for Kawasaki, most common in children aged less than 5 years, peak between 18 and 24 months. Atypical cases may not fulfill all the above criteria. If fever less than 5 days, but 4 signs above, persistent raised CRB and not other diagnosis, and no other diagnosis and suspicion of Kawasaki disease. Fever usually precedes the other signs, unresponsive to antibiotic. Common features, irritability, erythema of PCG site. So this is a tricky point. If you found the PCG injection site so far is erythematous, and you are suspecting Kawasaki, so this is considered to be a feature of Kawasaki disease as well. Other features include aseptic meningitis, uveitis, cough, vomiting, diarrhea, abdominal pain, urethritis, arthralgia, and arthritis. So in Kawasaki, we have arthralgia and arthritis as well. Urethritis, abdominal pain, diarrhea, vomiting, cough, uveitis, meningitis, aseptic meningitis. All these considered to be other features for Kawasaki disease. High risk features, already failed IVIG. So you already have given IVIG and there's a failure to respond to the treatment. So this considered to be high risk. Aged less than 1 year, severe inflammation persistently raised CRB despite IVIG, liver dysfunction, hypoalbuminemia, and anemia. Features of hemophagocytic lymphohistiocytosis, which is persistent fever, hepatosplenomegaly, cytopenia, more than 2 cell lines affected, hypertriglyceridemia, hypofibrinogenemia, increased D-dimer, hyper ferritinemia, which that's a high ferritin level, falling ESR. So that's features of what we called hemophagocytic lymphohistiocytosis. Okay, shock, evolving coronary or peripheral aneurysm, Kobayashi risk score more than 5. We have here a risk score called Kobayashi. You have to know about it, but it's not crucial. No one asking about it in the exam, but it's just what's Kobayashi risk score for yourself, for your knowledge. If you got more than 5 scores, according to the parameters in here, we have the sodium level. Sodium, it's 133 or millimole per liter or less. That's score 2. 4 days or less of illness, that's a score 2. ALT 100 or more international unit per liter, that's a score 1. Platelets less than 300, score 1. CRP more than 100, score 1. Aged less than 1 year, score 1. 80% or more neutrophils, that's score 2. Okay, okay. I will go back to the high risk features because it's very important. Who's the patients who are at high risk, if they already failed IVIG, less than 1 year of age, severe inflammation that's persistent with CRP despite IVIG, liver dysfunction, hypoalbuminemia, and anemia. Features of hemophagocytic lymphohistiocytosis, persistent fever, hepatosplenomegaly, cytopenia affecting more than 2 cell lines, hypertriglyceridemia, hypofibrinogenemia, increased D-dimer, hyperferritinemia, falling ESR, shocked, evolving coronary or peripheral aneurysm, and they fulfilling the Kobayashi risk score more than 5. Kobayashi risk score, sodium level less than 133, less than 4 days of illness, 4 days or less, ALT more than 100, platelet less than 300, CRP more than 100, age less than 1 year, neutrophils 80% or 80% or more. Okay, what's investigations? None is diagnostic. Full blood count, ESR, liver function test, urine, CSF, ECG, echo, throat swab for group A strep, anti-streptomycin or tetr, blood culture, urine analysis, microscopy and culture. If rash present, you'll do a couple of serology. Okay, that's in brief. I just read the outlines of the investigation. So let's take it one by one now. For blood count, what you are looking for, if there's a neutrophilia and thrombocytopenia. ESR and CRB elevated. Liver function test raised bilirubin, ALT, and low albumin. Urine sterile biuria, proteinuria is suggestive of an alternative diagnosis. CSF lymphocytes, you look for lymphocytes in the CSF for aseptic meningitis. For ECG, you may find ST depression, T wave inversion, and heart block. Echo, do not delay therapy before echo. Throat swab for gram-A strep, anti-streptozin otitor, azote, or anti-DNase B for evidence of streptococcal infection. Blood culture, urine analysis, microscopy and culture. If rash present, serology for enteroviruses, paravirus, Epstein-Barr virus, and cytomegalovirus. If features of measles, urine or throat swab in viral transport medium for PCR. So that's the investigations, the basic investigations in cases of Kawasaki disease. If you are suspecting incomplete Kawasaki disease. Okay, if you are suspecting incomplete Kawasaki disease, so you will find this, you will find that the children with a fever 5 days or more and 2 or 3 compatible clinical criteria, it's not going to be 4, or infants with fever 7 days or more with other explanation, CRB less than 30 milligram per liter and ESR less than 40 millimeter per hour. If fever persists, serial clinical and laboratory re-evaluation. If typical billing develop, echocardiogram. CRB 30 or more and or ESR more than 40. Treat if anemia for age, platelets more than 450 after 7th day of fever, albumin less than 30 gram per liter, elevated ALT, WBC is more than 15, urine more than 10 WBCs per microliter. So this is the signs of you can find in cases of incomplete Kawasaki disease. Again, children with fever 5 days or more and 2 or 3 compatible clinical criteria. So it won't be 4. Or infant with fever 7 days or more with other explanation. CRB less than 30, ESR less than 40. So it's not complete Kawasaki criteria at all. So in this case, if fever persists, serial clinical and laboratory evaluation should be done. If typical billing develop, you have to do our request echocardiogram after discussing with your consultant. CRB, if CRB 30 or more milligram per liter and or ESR 40 or more millimeter per hour, you have to treat. And you still have incomplete Kawasaki criteria. So you have to treat if there's anemia, if there's platelet 450 or more after 7 days of fever, albumin less than 30 gram per liter, elevated ALT, WBCs more than 15 multiplied by 10 power 9 per liter. Urine is more than 10 or more of WBCs per microliter. When to ask advice from pediatric rheumatology. So we have to involve the pediatric rheumatology in these cases. If we got incomplete Kawasaki, features suggestive of an alternative rheumatological or inflammatory diagnosis, aged more than 1 year, failed first dose of IVIG. So in these 4 situations, we have to consult the pediatric rheumatology, asking for advice from him, incomplete Kawasaki, feature suggesting that we have a rheumatology based disease. It's not a Kawasaki or simple Kawasaki. His age more than 1 year. He got IVIG, but he is not responding. So it's crucial in this case to consult the pediatric rheumatology. Immediate treatment. Okay. If we have confirmed that we have a patient with a Kawasaki disease and he is fulfilling the criteria, so you have to start the immediate treatment with aspirin, 7.5 to 12.5 milligram per kg, orally 6 hourly until febrile, or a minimum of 2 weeks. So you have to start with aspirin dose. That's the first thing that you have to do. 7.5 to 12.5 milligram per kg orally every 6 hours until he is afebrile, or minimum for 2 weeks. IV immunoglobulin, 2 grams per kg. IVIG 2 gram per kg. Check concentration gram per milliliter for preparation used in your trust. Administer at gradually increasing rate as below. So on this box we have to explaining how to increase the rate of immunoglobulin and the duration. So this is how to administer IVIG gradually. So until you reach the 2 grams per kg level, you will start with 30 milligram per kg per hour over 30 minutes, and then 60 milligram per kg per hour, or another 30 minutes, 120 for the next 30 minutes, and so on until you reach the to completion, until you reach your target. Volume will depend on concentration used, and maximum rate may be restricted by product literature. Okay, he's saying here that start IVIG 2 gram per kg as soon as possible. Delayed treatment, increased risk of aneurysm, monitoring IV infusion. Okay, IVIG infusion. So once you start the IVIG infusion, so you have to monitor that. Monitor temperature, heart rate, blood pressure, respiratory rate every 5 minutes for first 15 minutes, then every 15 minutes for first hour. So because there's maybe side effect or adverse reaction for IVIG, anaphylaxis maybe, so that's why you have to be careful and try to monitor every 5 minutes in the first 15 minutes, and then every 15 minutes for the first hour. Anticipate anaphylaxis, flushing, fever, headache, shivering. If tolerated, increase infusion rate to give total dose over remaining 10 hours and monitor hourly. So that's why we have to start gradually, gradual manner. We don't start with a big dose from the first place because there's a risk for anaphylaxis. If mild reaction happen, stop infusion for 15 minute, then restart at a slower rate. It's very important to know this and bear it in your mind. High risk features present. Okay, if we have a child or patient with high risk features, we will start aspirin and IVIG as above. We will add methylprednisolone 0.8 milligram per kg IV 12 hourly for 5 to 7 days or until CRB normalized. Then prednisolone 2 milligram per kg per day, oral and wean over 2 to 3 weeks. So we consider giving steroids or the prednisolone, methylprednisolone, if we have a high risk features we have spotted in our patient. So we will start aspirin and IVIG. We will add on top methylprednisolone, 0.8 milligram per kg IV, 12 hourly up to 7 days, 5-7 days, until we got normal CRP level. Then we switch on to prednisolone, 2 milligram per kg per day orally, and wean over 2 to 3 weeks gradually. Okay, what's the subsequent management? If fever persists 36 hours after completion of IVIG, consider a single repeat dose of IVIG. If fever persists after a second dose IVIG, discuss with pediatric rheumatology and consider methylprednisolone IV as above if not already given. Discuss with pediatric rheumatology about infliximab. Fever settled for 48 hours, clinical improvement and falling CRP. Falling CRP, reduced dose of aspirin to 2 to 5 milligram per kg, maximum 75 milligram, oral as single daily dose for minimum 6 weeks until result of echocardiogram known. Okay, so it's very important to know the subsequent management because it's gonna guide you which direction you can pick in your next management. And side by side, you have to consult your pediatric consultant and your rheumatologist consultant as well. So in here saying if fever persists 36 hours after completion of IVIG, consider single dose. We have to give another single dose of IVIG once again. If fever persists after the second dose of IVIG, so you have given the second dose, but he's still having fever, so you have to discuss with the pediatric rheumatology, and you have to discuss giving methylprednisolone IV because it's considered to be a high risk Kawasaki feature. Discuss with the pediatric rheumatology about infliximab. On the other hand, if fever settled for 48 hours, he is clinically improving, CRP is falling, we have to reduce the aspirin dose 2 to 5 milligram per kg orally as a single daily dose for a minimum 6 weeks until results of echo known. Okay, so let's move to discharge and follow-up now. This discharge, the patient when fever settle, echocardiogram at 10 to 14 days and 6 weeks from onset of signs and symptoms. So he will got 2 echos to be done. The first one is going to be 10 to 14 days after the signs and symptoms onset, and then at 6 weeks after after that. Outpatient appointment 1 week after each echogram. So once he done the first echo, he has to got appointment in 1 week time after that echo. Advised to avoid excessive strenuous activity until outpatient appointment after echo. Advised to avoid all live vaccines, for example, like MMR, for 3 months following IVIG. So that's very important advice to give to the parents. All live vaccines prohibited for 3 months after the IVIG dose. Outpatient management. So we already discharged the patient, but he has to follow up with in the outpatient clinic from time to time. So this depends on the echo results. So if he has done echo and he got an outpatient appointment 1 week later, and you have found that no aneurysm at 6 weeks echocardiogram. There is no aneurysm. He doesn't have any aneurysm on the echo at the 6 weeks appointment for echo. So in this case, we have to stop aspirin, no restriction on his activity. He has to follow up at 12 months and discharge if well. So this patient has to stop aspirin, no restriction on daily activity. He will have a follow-up at 12 months from this appointment and discharge completely if he is doing well. Okay, if he got a single aneurysm and less than 8 millimeter in diameter, he will stay on aspirin. He will keep taking aspirin 2 to 5 milligram per kg once daily until aneurysm disappear. Cardiologist will advise on limitation of activity, exercise stress test, MR or CT angiogram, 6-monthly ECG and echo, lifelong follow-up and advice on reduction of cardiovascular risk factor. So that's if one patient got a single aneurysm less than 8 millimeter in diameter, he will keep taking aspirin 2 to 5 milligram per kg once a daily until aneurysms appear. Cardiologist will advise him about the limitation of activity. He may need MR or CT angiogram for his blood vessels or coronaries around his heart. He will need to do ECG and echo every 6 months, and he will need indeed lifelong follow-up and advices for reduction of cardiovascular risk factors. Okay, if another patient got multiple or giant aneurysm or stenosis, as for single aneurysm, and lifelong aspirin 2 to 5 milligram per kg per day, we add on top warfarin after heparinization. Okay, he has to take warfarin as well on top of all the previous management. Okay. We have the pediatric inflammatory multi-system syndrome. We try to read it so quick. Pediatric inflammatory multi-system syndrome. Discuss patients who are deteriorating or have hemodynamic compromise with local retriever PQ as per local pathway. Discuss all patients with local BIMS, TSMDT. These are the rheumatology, infectious disease, cardiology, and PQ. to confirm diagnosis and decide on treatment. So pediatric inflammatory multisystem syndrome is a complications of Kawasaki disease. If the patient develop pediatric inflammatory multisystem syndrome, so you have to discuss all patients with the local BIMS TSMDT, which are rheumatology, the infectious, the cardiology, and PQ. Rheumatology, infectious, cardio, and PQ. Where available treatment should be on a recognized clinical trial. Okay. The diagnosis. We have a link here for the pediatric inflammatory syndrome associated COVID-19 guidance. This link. But we will go through this in brief here. We cannot go through the link now. Okay, so the presentation, presenting with persistent fever, inflammation, neutrophilia, elevated CRP, and lymphopenia. So neutrophil count will be high, elevated CRP, and lymphocytes going to be low. Evidence of single or multi-organ dysfunction, like, for example, shock, cardiac compromisation, respiratory, renal, GIT, gastrointestinal, neurological, may include children fulfilling full or partial criteria for Kawasaki disease, exclusion of any other microbial cause, including bacterial sepsis, staphylococcal or streptococcal shock syndromes, infections associated with myocarditis, for example, enterovirus. Waiting for results of these investigations should not delay seeking expert advice. SARS CoV-2 PCR testing may be positive or negative in this case. The clinical features all is going to have a persistent fever more than 38.5 centigrade. Most of them will need oxygen requirement and hypotensive. Some of them will have GIT, abdominal pain, diarrhea, vomiting, and cardiovascular symptoms as well. Syncope, respiratory cough, shortness of breath, mucosal cutaneous eye symptoms, investigations, the hematological investigations, that's full blood count, clotting with fibrogen and D-dimer. Full blood count, clotting with fibrogen, D-dimer, biochemistry, urea electrolyte, liver function test, albumin, LDH, anti-streptolizin O tether, triglycerides, ferritin, troponin, and creatinine kinase. The microbiology, COVID PCR and serology, if PCR negative, Epstein-Barr virus, cytomegalovirus, adenovirus, enterovirus on blood, urine dipstick cultures, blood, urine, and stool. Common blood abnormalities, none are diagnostic, that we can find these blood abnormalities in these patients: lymphopenia, neutrophilia, elevated platelet, thrombocytosis, raised CRP, raised ESR, low albumin, raised ALT, raised D-dimer, elevated troponin, pro-BNP as well. Other investigations, ECG variable features including ischemia and echo were available. Normal impaired function, coronary artery abnormalities sometimes. If respiratory symptoms, you do chest X-ray. If abdominal pain, abnormalities on examination, abdominal ultrasound. The management, the first thing that you have to think about in this situation, that you have to where appropriate, BBE. Standard ABLS, Advanced Pediatric Life Support Resuscitation. As I mentioned before, we will read these guidelines in another video, inshallah. Broad spectrum antibiotics, cefotaxime, add clindamycin if features of toxic shock. Call local retrieval team or PICU early. Patients can deteriorate quickly and require early initiation of inotropes guided by PICU. So you will need to use the inotropes guided by PICU in these situations. Decision on further immunomodulatory treatment to be made by local BIMS MDT, which are again, to remind myself and you about this team: rheumatology, infectious, and cardio and PICU, ideally on a recognized clinical trial. Okay, so in here, the immunomodulatory treatment, it's still on trial. It's not approved yet, according to the guideline in here. They don't start it yet. Monitor for signs of clinical deterioration, cardiovascular, respiratory, CNS, and abdominal, and signs of worsening inflammation, including HLH. For follow-up, long-term outcomes are not fully known. Follow-up in center with expertise in managing patients with BIMS TS. So it needs a very, very, very special center for that, with expertise in this kind of complication. Outcomes for patients have been favorable to date. Okay, so we have finished the Kawasaki disease and multi-inflammatory pediatric inflammatory multi-system syndrome as well, which is very important, and they ask about it in the clinical exam very often. I hope you enjoyed this guideline, and see you in the next video.